it's really exciting to start out a meeting like this and talking about child development as we talk about reducing global violence. And it's been really my honor to be here and to be involved in a rich discussion. I want to thank UBS Optimist Foundation. I want to thank the WHO. I want to thank Manuel for all his organizing. And we had a wonderful day discussing the integration of early childhood development and violence prevention yesterday, sponsored by UBS Optimist Foundation. So I'd like to share a little bit of that with this full group today, this morning. So I'm going to be talking about linking developmental science and prevention research to address child development and prevent violence. I'm going to talk a little bit about some of the links, first of all, and I'm going to touch on some of the key principles in the way forward. I'm going to talk a little bit about field-based work that I'm involved with in Rwanda and an initial model that we've been developing to bring together the prevention of violence, but also the promotion of early childhood development in families facing extreme and compounded life stressors. And then also present, and Manuel said he was really looking to push us beyond our comfort zone to talk about some future directions too and how these two fields can be integrated. Because really the ECD, the early childhood agenda, has taken off. But I think the goal of people like ourselves here today is to link violence prevention to that. And there's really an opportunity as ECD gets growing attention, funding, and political will behind it. So we have to think about some strategies for that. So myself and Chris Mickton, who was a really tremendous part of putting this meeting together, Terendua and Harriet McMillan just published a commentary in the Lancet Global Health about the interplay of prevention of violence against children and early child development. And I'm going to lay out some of those same arguments in my talk with you this morning. So first of all, many of us are galvanized by this reality that around the world, a third of children under 5 are failing to fulfill their full developmental potential. And this has really been a call to action from the Lancet series that has galvanized the early childhood development field. And certainly what we see around the world are overlaps between poor child development outcomes and risk for violence against children. And you all know many of these numbers, but we're seeing now in some of the surveys, even from the CDC Global Violence, the Violence Against Children surveys, that in some parts of Africa, up to 3/4 of children are victims of child physical abuse. When it comes to sexual abuse, a third of girls and over 10% of boys are at risk. And then when we look at child adversities in many different settings around the world, what we're seeing is a co-occurrence and an overlap. So this is work from Ron Kessler, who looked at child adversities in 21 high, middle, and low-income countries. And he found that adversities such as child maltreatment, low maternal education, family violence tended to co-occur. They were highly prevalent, and their co-occurrence accounted for 30% of later mental disorders. Now we see the same thing in health outcomes as well. Child adversities linked to adult chronic health problems across the life course have been documented in a range of studies. We see links between early child adversity, including child maltreatment, but also some of these chronic conditions of stress and poverty linked to diabetes, cardiovascular disease, depression, and alcoholism across the life course. So starting early and thinking about prevention science is really critical in our field as we think about halving violence around the world. Now to talk about the overlap a little bit more, we see that there are shared risk and protective factors, both in the promotion of early childhood development and what the risks are for poor development in children, as well as risks for violence against children. So we know from systematic reviews that child maltreatment is causally related to a broad range of negative life outcomes across the lifespan, as I've just talked about, both in mental health as well as long-term adult health. And we see also that children who have developmental delay are at greater risk for violence. So this comes from a review of children with mental or intellectual disability, where they showed that they have a more than fourfold increased risk of any type of violence. Similarly, we know that growing up with exposure to adversities such as poverty, parental psychiatric disorder, and institutionalization are also shared risk factors for both, risk factors for violence against children and risk factors for poor developmental outcomes in children. But also there are some promising protective factors that are shared across the two, and we need a lot more work in the field about these. But we see protective factors such as maternal education applying both to lower risk for violence against children and better developmental outcomes. And we need to articulate these shared risk and protective factors a lot more to understand mechanisms of change. Now, when it comes to what do we do in terms of addressing child development and prevention of violence against children, we see a lot of overlap in the types of programs we use. Typically, we see programs targeting parents or elements of the family context, including increasing attention also to other elements of parental functioning, such as substance abuse, such as parental mental health problems, which is really important for our field to begin to broaden and think about context. And also when we look at violence prevention efforts and some of the intervention models that are used are standard models that you would use in early childhood development, such as home visiting programs. So why aren't we bringing those two together? You know, we're having this contact with families already in one domain or the other, but there's a real opportunity to look at their synergy and their interplay. Also, when it comes to who's at the table in terms of key sectors, in terms of stakeholders and professional groups, we see the same groups when it comes to prevention of violence against children or when we're talking about early childhood development. We're seeing the health sector, the social welfare sector, educational sector are likely to be involved. When we're training human resources, oftentimes we're training frontline healthcare professionals, social services personnel, and educators who are involved in the response. So there are real opportunities here to think about infusing both of these topics together in their interplay. But to get there, as we heard in Alex's comments, we have to think about crossing sectors and silo busting. So I wanted to talk a little bit more about this need for silo busting when it comes to promoting child health and development and preventing violence. What we have in our field right now, as many of you know, is this problem that we address these issues in silos. So health being separate from child welfare, being separate from thinking about educational responses. And what we really need are more holistic responses to child health and violence prevention. And to begin to think from an early child development prevention perspective rather than just reacting after the fact and focusing on integrated policies and integrated programmatic responses. So one model that we've been writing about in recent years as a way of thinking about this is something that we call the SAFE model. Whereas in the child survival movement, it was very useful to remember the do not forgets of promoting child survival, GOBI, growth monitoring, oral rehydration, breastfeeding, and immunization. When we're talking about SAFE, we're talking about the basic security needs and rights of children. And it's a rights-based model, but it's also talking about how the interplay of these very essential core domains of children's security. The do not forgets of children being able to have the basic foundations to thrive. This is not the UN Convention on the Rights of the Child. We're really talking about the basic platform here, that being the gold standard for children actualizing all their rights. And so when we talk about SAFE, we're talking about, first of all, fundamentally, freedom from harm or safety. That's the S in the model. Secondly, access to basic physiological needs, food, shelter, a standard of medical care that's adequate. Also, we know from centuries of developmental science that children need dedicated attachment figures. That's the F, the family members, and this can take many different forms, but all children need them. And then E, economic security and educational access. And that's really about the future course that children are on in their lives and the security of the family. And what's important to consider here is that rather than a hierarchy of needs where you stack one on top of the other and you say, maybe we'll stop here because we've met the basic needs, you can't splice those out when you're talking about child development. They are interdependent and interrelated, and they influence one another. And you can see this in examples such as I've worked on the topic of child soldiers in Sierra Leone for now 13 years. Children who lack caregivers, who don't have their basic physiological needs met, or who don't have their basic needs for safety met, are much more prone to be involved in armed groups to meet those needs. And so you see children engaging in survival strategies, which can take risky forms like children joining gangs or an armed group to survive, or they can take adaptive forms. So in Rwanda, where families to meet their security needs, their basic economic needs, would need to work but didn't have childcare, didn't want to leave their children unattended, they would organize into informal collectives to watch each other's children. That's an example of an adaptive survival strategy. And what we want to do is identify those adaptive strategies and support them and work to identify the risky strategies and provide alternatives.
So when it comes to thinking about violence against children in early childhood development, this is one way to think about that interplay. So you might have a family that's extremely impoverished, and I'm going to talk about a program for families that are living in extreme poverty in Rwanda, where the household provides little stimulation for early childhood development. There's low monitoring of children and high stressors in the family. This can easily lead to many different forms of insecurity, including intimate partner violence in the family and child maltreatment. Also interruptions then in attachment relationships, where you have a mother who may be abused, is depressed, unable to attend to her child's basic developmental needs, and substance abuse in the family. And as a result, you have a child showing up in the health system who's sickly, malnourished, has poor school readiness. But if you try to address this just from a health sector sort of approach, you're going to be very limited in your impact unless you're thinking holistically about all those different interrelated domains of children's basic security needs. So in thinking about models like this that could help to think more holistically about family functioning, we began some research on understanding family adversity and early childhood development in Rwanda, and I'm going to talk with you a little bit about that process, which began in 2007. Now, my team and I are a mixed methods research program. We really work to integrate synergistically qualitative research methods and quantitative as we're moving into new cultures to which we're outsiders and really building partnerships with local teams and investigators. And we start with saying, we don't really know how these constructs such as good parenting are manifest in a new setting, or social support, or childhood depression. What does that look like in Rwanda? And to assume that measures or constructs that we use in the United States or the UK fit could really lead you down a path that's going to be not very informative, or the wrong path. And so we start from the ground up, trying to understand these constructs in terms of local terms that people use. What are the indicators of good parenting in Rwanda? And we found very quickly that the standard parenting measures didn't necessarily apply. You have items such as parenting for the good of the nation. Do you think we see that in our standard parenting schedules in the United States? Not very much. And then we learn things such as, how do they think about social support? How do they think about connectedness in the family? And then use this information to think about selecting, adapting, creating new measures. But also we learn about dynamics related to adversity in families. And this original work started in the context of HIV. So we talked with families about, despite HIV, how is it that some families manage to do okay? What are the key aspects of family functioning that lead to better outcomes for kids? And then once we have that information, we come in not only to look at measures, but to look at intervention models that are evidence-based, that can be adapted to the context, or creating new models of intervention that really come from the work. And now we can come back and evaluate these using the most rigorous designs possible. And this is really a process that can iterate across different settings. We've used methods like this in Sierra Leone, in northern Uganda, and now with refugees in the Boston area as well. So the family strengthening intervention really followed this process across its many steps. As I mentioned, it started in the context of HIV with funding from the National Institutes of Mental Health. And what I'm going to talk about is how we're moving that now into early childhood development and the prevention of violence. So we began with qualitative research on mental health problems in kids and how those were understood locally and their key indicators. Also on resilience and protective processes and how we could understand those from a local perspective. And then we moved into adaptation and development of measures, a validation study, and also an adaptation of an evidence-based intervention that I'm going to talk with you about. And then we were able to use these tools in conducting epidemiological studies. We just published in the journal Pediatrics a study looking at mental health and protective processes in children living with HIV compared to those affected by HIV. So you're talking about the family stressors and the broader impact of adversity on the family compared to children unaffected by HIV. And we see very similar risk factors between children living in the context of compounded adversity compared to those who actually live with the virus. So again, it speaks to how those risk factors cascade across all levels of family functioning, even kids who aren't directly affected by the main risk factor. And then we've been able to move into thinking about prevention models, an initial parenting, a family-based preventative model that I'll discuss. And the idea is eventually to move towards larger trials of effectiveness and also implementation research questions. So the family strengthening intervention is an adaptation of an evidence-based practice, the family-based preventative intervention, originally developed by Dr. Bill Beardsley, who's an emeritus psychiatrist at Children's Hospital in Boston. And we were particularly interested in the work for low-resource settings because it was designed to be delivered by a wide range of health providers. You don't need advanced graduate degrees to do this kind of prevention work. And it's family-based. It focuses on improving the parent-child relationship and communication in the context of chronic health conditions and adversity. And he originally developed this work for the prevention of depression and the offspring of depressed caregivers. Our work in Rwanda is the first attempt to adapt this to sub-Saharan Africa and also to the context of adversity, multiple forms of adversities in families. And we saw this as a good fit for the setting and context, given what we had learned from our formative work in Rwanda in the first place and working with community advisory boards. Now, the original intervention was brief, very much a strengths-based intervention. It involves 6 to 11 sessions that are done at the household. We follow a manualized protocol so you can look at fidelity to the evidence-based practices. There's a detailed set of training materials. And because we've done all this qualitative work, we're able to bring in proverbs about child rearing, about strengthening families, and ways that people can really connect to the content, even if they're not literate. We also hold weekly meetings between family and an interventionist who visits the home. And there are separate sessions for younger children, as well as we convene eventually a family meeting that parents may go on to do towards the end of the intervention. Now, I just want to show you some of our initial data from this intervention. This is an open trial with 20 families in the Kayanza district of Rwanda. They had at least one HIV-positive caregiver in the home and a child in the home between the ages of 7 to 17. About half of these families are single caregiver families. And again, this is a preventative intervention, so we're not selecting people into this open trial who are at high symptoms. So that we see any change in these protective processes isn't likely due to regression to the mean or something like that. We're actually seeing improvement. So we think there's a signal there about hitting some of those core mechanisms of protection. So we're seeing both in the child report and the caregiver report, especially in the caregiver reports, and there are lots of issues with that, around family connectedness, but also increases in the sense of good parenting. Even at pre-treatment, post-treatment, and 6 months of follow-up, the parental sense of self-esteem and perseverance, and pro-social behavior in the children. So definitely on the protective resources, some real traction with the parents, which makes sense because this is really an intervention that's working mainly with the parents. And then we're looking at their children over time. But we do then look at mental health issues, including conduct problems, which can relate to later violence amongst the children, but also issues such as harsh punishment within the family, both from child report and caregiver report. And again, we're seeing in both those reports decreases in children's symptoms of depression, anxiety, conduct, beginning to see some trends but not as strong, and certainly decreases in harsh punishment. So there's a signal there that's very interesting and exciting to think about as we move into early childhood. Now, to talk about early childhood, these are some slides that I borrowed from the Harvard Center on the Developing Child. And looking at adversity and its impact on developmental delay, we know that as a number of those types of risk factors we talked about earlier, poverty, poor maternal education, substance abuse, child maltreatment, as these increase, we see greater risk for developmental delay in children, especially as we see an accumulation of these risk factors across the lifespan. And we know that early life experiences get built into our bodies for better or for worse. So we know that research on the stress response shows how adversity raises heart rate, blood pressure, stress hormones, really fuels the body's fight or flight response. And this poses a threat to brain architecture as it's developing in young children, influences their immune status, metabolic systems, and also cardiovascular function. And we've seen that in a lot of mechanistic work on stress in young children. And when we talk about stress in young children, we have to think about different levels of stress. So some forms of stress are positive, such as getting up in front of a group and giving a presentation to people that you respect a great deal. You know, these are associated with brief increases in your heart rate, mild elevation in your stress hormones, having a child get up and be in a school play or give a recital, same sort of thing. But you get through it, you learn from it, you do it again, you begin to enjoy it. Very important learning experiences for young children. There are also tolerable stress experiences, and these are things like going through a frightening accident or a frightening medical procedure, where again, for children, we see responses in the bodily stress response, but these are buffered largely by those attachment relationships, and the child is able to get through them. Then we move into the sort of stress we talk about when we think about repeat adversity in families, violence and child maltreatment, substance abuse, and parental mental illness. This is the domain of toxic stress. And we're talking about prolonged and repeat activation of the bodily stress response system in the absence of those buffering relationships if they're impaired, or in some cases when caregivers aren't even available, as we see in the case of child soldiers. So when we come to thinking about how to prevent these negative outcomes in children, we know that supportive relationships and positive learning experiences begin in the home, but these can be supported by outside assistance when families need the help. We need to think about a balanced approach between the social, the emotional, the cognitive, and language development of children, and think about specialized interventions as early as possible for families facing adversity. So this came to the opportunity to think about how could we take these parenting interventions that we've been doing in Rwanda and think about reaching the most vulnerable families. Now, when you see ECD scaled up in a lot of low-resource settings, what's often happening is they're building ECD centers. So it's bricks and mortar, it's centers, but it's not a lot of attention to what's really happening within those walls. But with a range of different options, we can think about, for the more severe, having more intensive models like family home visiting, as well as community-based and center-based care to promote child development. And this is where models like ours come in. And this collaboration has been with the Rwandan government through their flagship social protection system, the VUP, where they're identifying families at the lowest levels, the sort of lowest rankings in terms of economic self-sufficiency by Ubudehe level. So these are families most at risk, where there's a lot of these different sort of stressors in the household. And adapting this intervention model so it can tag into that system, the social protection system, which is really exciting for thinking about alternate ways to deliver early childhood development in different settings. So again, as you saw in the family strengthening intervention, it's meant to be flexible. We're bringing in the components related to early childhood development from UNICEF's Care for Development modules, and also violence prevention content from what we've learned in working with families in adversity and families affected by violence in many settings. It builds on the current parent training model by having direct coaching interactions between facilitators who go to the home and families of many different configurations. But an exciting part of this is that we can involve fathers, and we're not just reaching those who come to a center-based program or a group, but we can work with the whole family in many different configurations. And getting back to the SAFE model, this is also an opportunity to help families navigate resources, formal and informal supports across all of those key domains where they have security needs. So here's the conceptual model. So we're targeting very poor families with children ages 0 to 3 who are enrolled in Rwanda's social protection programs. We know that some of the big risk factors here are that there's very little understanding about promotion of child development, and that the baby's brain is developing and growing when they're so young and don't even talk yet. Limited opportunities for stimulation and learning in the household, especially when parents don't have literacy themselves. Oftentimes for a family, poverty is a real crisis, so it feels like there's very little attention to the future and the journey the family's on together, and future planning. Then getting back to just the economic stress that I talked about earlier in the SAFE model, and risk for maltreatment of children. So core components of the intervention that relate to that are basic content related to child rearing, to nutrition, to health and hygiene, as you see in the UNICEF Care for Development modules. But then also this really close attention to responsive parenting and coaching, and working with the family in their household, pointing out, did you notice that when you played with your baby? Did you see how they responded? Sometimes when we get frustrated, we may respond in this way. How about trying some of these different techniques? And beginning to really make it playful and fun and empower parents to have additional skills. And then also telling the family narrative, which is a great way to move out of this sort of crisis orientation, starting to talk about the story of the family as a resilient story. And these are, in Rwanda, a lot of these families are genocide survivors. They've been through really horrifying things in the past. What helped them to make it through? Telling that story about resilience and identifying strengths in the family. And then also building self-regulation skills. So when you're getting keyed up, what are things that work for you? Teaching some techniques in terms of giving yourself a timeout, deep breathing, stress management for parents. And then alternatives to harsh punishment in children, positive parenting techniques. And the result, and hopefully the outcomes of all of this, is improved parenting practices and improved overall child development and reductions in child maltreatment and violence in the household.
5 minutes.
Okay. As you can see, I speak quickly. So these are some of the core content of the modules. We're certainly working with the family early on to engage them in talking about their own priorities and goals for their children. We early on in the intervention, this is the Apple to MS Word conversion. It's very interesting. We began to talk about how you can provide opportunities for early stimulation in the household, developing language and communication skills, responsive parent-child interactions, and then the basics of hygiene and food consumption. But throughout this, we're threading stress management and alternatives to harsh punishment. We talk about promoting basic health, but also the consequences of conflict in the household and the importance of promoting peace for child development. These are just some of our modules on conflict resolution. We talk about the consequences of children being exposed to violence and the importance of what you're modeling for your children, and describing how good communication and conflict resolution has benefits for the whole family and also for your growing children and their own success. In societies affected by violence like Sierra Leone and Rwanda, these concepts of emotion dysregulation, emotion regulation are very important. So teaching parents those coping skills so that they don't rely on violence or angry interactions with their children when they feel under stress is really critical, and I think an important part of how we can think about some of these parenting interventions, what elements we might add in violence-affected conflict settings. And this is an opportunity also to discuss the impact of drugs or alcohol, or looking at issues related to parental mental illness and making referrals and helping families navigate those different support systems that are out there, both the informal as well as the formal. So just to wrap up on these family-based interventions, I think in summary we see that doing this sort of work to address early childhood development and promote peaceful interactions in low and middle income countries and low resource settings and violence-affected settings is feasible. It's acceptable to families. This violence prevention element requires more ongoing and careful attention. We're seeing even in some of our early research when there are dual caregiver families versus single, there are differences, and we really need to attend to that and understand some of those mechanisms. Just like David Old's program, we're seeing bigger benefits in the single caregiver families. So what can we do more when there are mothers and fathers in the household or different family configurations? We need to understand much more about effectiveness and really bring these sort of small pilots to larger trials so we can really get a sense of effect size, and then move into implementation research questions to think about scale and sustainability. And I'm going to talk a little bit about that. Oh, more conversion. It takes away the font. So in terms of advocacy, I'd like to just close and talk about bringing the ECD and violence against children prevention fields together. That we really need in groups like this to begin to keep up pressure to make this a political priority, that there's mutual investment in ECD, but also within that, prevention of violence against children. And this means looking at the integration of these two fields in laws and policies. Do they reference one another? Does the ECD policy talk about violence? Does the violence prevention policy talk about ECD? Funding sources, thinking about programs that really look at multi-sectoral work and promote research that's integrated. Human and institutional capacity, we're training one or the other frontline worker to do these things separately. Can we bring that together? And in terms of research and evaluation and program implementation, I have a few specific recommendations. And then the multi-sectoral collaboration is going to be required at regional, national, and international levels. So to think about programming, this may require making these aspects of our work that you're trying to prevent violence and promote child development, making that explicit in your theories of change. And that means having your conceptual models that link to what are your core components, that link to what do you choose to measure afterwards. And beginning to address, are we missing components if we're trying to do both? How can we strengthen those elements in an intervention model? And then in research, making sure that when we do these big surveillance studies, that we have questions about both of these things, that we have questions about child development along with the questions on children's exposure to violence, both in surveillance but also in our outcomes measure and in our longitudinal studies, so we can begin to understand mechanisms of change and the synergies between child development and violence prevention. And that's really going to be critical for understanding leverage points in intervention. So in terms of identifying integrated research priorities, I think there's tremendous work to be done on valid indicators of the co-occurrence of violence against children and poor ECD. Thinking about affordable and effective interventions, we've talked about sort of having a menu that moves from the intensive family home visiting to community-based group work to center-based work, to begin to look at what are the costs of those things, to look at cost savings if we address the capacity and well-being of caregivers when it comes to substance abuse, intimate partner violence, mental health problems. And then as a field, we can't stop with our randomized control trials. We have to think about implementation research. How do we take these evidence-based practices to scale? How do we sustain them? How do we ensure quality? And what are their essential components? And eventually we can move then to thinking about cost effectiveness in the different models we choose. So just to wrap up, I think there's a real need to accelerate the knowledge translation about this integration of ECD and violence prevention. And this means including people like yourselves from the very beginning, policymakers, researchers, funders, program developers, and to build these collaborations with attention to the integration throughout every step in the process. And to really, as a field, for us to latch on to these calls for greater attention, not to just child survival, but the context of child development, children thriving. And when they talk about ensuring that all children have the opportunity to grow up in conditions that promote their optimal health and development, that a critical part of that is prevention of violence. So with that, I'll wrap up and thank you.
Just, whoa. Would you facilitate the discussion?
So, thank you very much.
And
I can't leave because I'm president.
thanks. Well, then that's just fine. You don't need to leave. Stay right there.
Well, do you want me to stay here?
Maybe the
Here we go.
technician can help.
I'm Heather.
So